Next, I welcome Dr. Suneel Godbole for the next topic. As a general pediatricians, we happen to see many cases of autism nowadays. Even though we are referring to developmental pediatrician, we should know all the aspects of autism. That includes medical and behavioral comorbidities associated with autism and its management. So this topic will be presented by Dr. Suneel Godbole. He is a developmental pediatrician from Pune. He is currently a secretary of IAP chapter GDBP, and now only he has taken up charge of chairperson. He is one of the pioneer in growth and development. We are keen to listen to you, sir. Over to you.
So I, at the outset, thank the organizers and all of you to be with me for this journey till now. And today I'm going to go for a very rapid discussion on an important topic. Can you give me the slide, please? So you always we discuss about autism, and when we discuss about autism, we have got many more other things also. And the parents don't always come with only one thing as autism. They come with something more to that. Sometimes they come that it is ADHD. Sometimes they call it like a learning issues. But actually, what we are going through is something unique. And when it is not only autism, we need to think of. It's not working. Okay, so autism has too many friends. That's the message I wanted to start with. And it is not only one disease we are going to treat, we are going to treat these friends as well. So I'm going to discuss about these medical and behavioral problems. But to just highlight, and if anybody wants to sleep after for the next 20 minutes, and he can remember only this slide. So the manifold comorbidities of autism, first one is genetic, then cognitive, behavioral, and the last is the medical part. In the genetic, we have got lots of syndromes. I think we have been discussing about this genetics since morning. But I want to highlight only two just to think how we are going to look at these combinations over the time. So the Fragile X syndrome, this is a very cute Fragile X when there is a X chromosome. It's a X-linked dominant disease with a X chromosome looking fragile or broken at the site of mutation. This is what it is, why it is called as a Fragile X. The chromatin gets condensed at that point. That is the reason it is happening. And in this Fragile X syndrome and autism, it's quite a big number. 1 in 4,000 males and 1 in 8,000 females, obviously suggesting that the males are commonly presenting with Fragile X than the females. 46% of the males and 16% of the females with Fragile X syndrome have ASD. So this is one thing we need to know about the association. While 2 to 6%, now let's do it other way around. 2 to 6% of the children with autism have Fragile X syndrome. So when you see 100 cases of autism, you need to remember that there will be 2 cases of Fragile X syndrome and we should be aware of it. Second part, how to find this out. This cartoon I leave again. How to find it out? Elongated face, broad forehead, large protruding ears, mental issues, along with joint mobility which is increased, and macroarchitecture. The testes are larger in these cases. So this is a typical class of a Fragile X syndrome. So Fragile X syndrome is known to be leading cause. Why it is important? Because this is one of the genetic disorders which is highly connected with autism. So that is why, because we always say genetics, as we were listening and we listen many more, so many mutations and so there. But it is one of the conditions where it is together. So what is now common and different? We are going to discuss these comorbidities like that. The common, the different with Fragile X is unique facial features, intellectual disability, hyperarousal. These children are anxious. Their surrounding, they are aware of, but very important in autism, the surrounding awareness not there. But in Fragile X, the awareness of the surrounding is good. They got delayed. They got a pretend play which is okay. They got good at imitation. Again a difference. In children with autism, imitation is not good, but in children with Fragile X, the imitation is good. So to compare poor speech, when it is the unique, it may be good in this case also. And common, poor eye contact, poor speech, self-injury, limited social connect, these are common with Fragile X and autism. But the two things which differentiate is the delayed pretend play in Fragile X while distorted pretend play in autism, and that's how we differentiate them. Down syndrome. Again, unfortunately, it is a dangerous combination. A Down syndrome and autism, about 16 to 18% of people with Down syndrome also have Downs. While Down syndrome is genetic, autism is neurodevelopmental. So this difference we should know. So they can be comorbid conditions. But a child who is having Downs, is it necessary that the child should be having autism? No. A child with autism, is it necessary to have Downs? No. They are different entities and they will be just comorbidities. So again, to compare Downs, unique facial features, which is not in autism, they are very commonly. Intellectual disability, children with autism may be very intelligent. Health problems are common with Down syndrome as it is not that common in autism, while the children are very friendly. And what children with autism missing? That friendliness is missing with children with autism. These children have love of music, which autism children do have, but they cannot present them. While the common thing is delayed development, limited self-help skills, reliance on routines. They are always relying on the routines, while need for love and support is required for both of them. So that is the difference between these. So how to differentiate? A very quick idea. Down syndrome look different, while autism behave different. So that is the difference between two. Now we let go for the cognitive comorbidities. Here come the two parts, the intellectual part and the developmental language disorder. In intellectual disability, the degree of intellectual disability is directly proportional to the severity of autism. That's one thing we have to remember. Up to 50% of individuals with severe learning difficulty have autism. And not only that, if we do plot a non-verbal IQ of these kids, 70% and less than 70 IQ are ASD, while 5% of autism spectrum disorder high functioning present with intellectual disability. So this is another thing which we should be remembering when we are comparing IQ and autism together. So in intellectual disability and in autism, what we find, low IQ. In autism, there can be average IQ in 5 to 10%, higher than normal IQ. Limited understanding, learning issues, speech which is average, normal eye contact, that is important in intellectual disability, but evenly low development. So all the parameters are going down. When it comes to autism, it's an uneven development, and there is a concept called as a mind blindness. These children are unable to connect with others again, and so they cannot read the mind of others or the memory neurons, which is not so in intellectual disability. But what is common? Poor speech is common, inattention is common, learning issues is common, self-help skills problem, they are common, and it's a lifelong in both the cases. Now the developmental language disorder, however the child has a language difficulty that create barriers to the, now it is only language, it is not autism like that, it is only language. Because of language development which is not developed in the first 5 years of life, the problems are not associated with any biomedical condition like brain injury or neurodegenerative conditions or chromosomal disorder. So developmental language disorder, you can look at it as an isolated area of language. Now let's compare these two. In developmental language disorder, it is usually isolated. It goes unrecognized for years. And what Meenakshi Madam was telling us, it is diagnosed at a very early age. Autism we can pick up at a very early age. This is not medical diagnosis, it's more of a academic, more of a speech therapist, language therapist diagnosis. It's quite common as compared to the autism. But again, because a poor language development, there is a social communication issue. And because there is a social communication issue, they start comparing and contrasting with each other. Now the third part is the behavioral comorbidity. This is the area which I am going to dwell a bit more. First part is a new terminology which has been coined in April 2023. AUDHD. We used to say ADHD and autism separate. But now what? Laura is saying that it is autistic plus ADHD. ADHD and autism 30 to 60% combination. ADHD in typical 6 to 7%. So that tells us that yes, in autism, ADHD is definitely important. 50% genetic overlap in these two conditions. As against that, a conflicting need. Now this is important. A child with ADHD, you can remember me, a child with ADHD can't sit at one place. So he has to move. Always an internal battle of movement. While I'm getting connected with people, moving around. Well, in autism, not connected with the people again. So this is a typical different pattern. So it's a very difficult combination to have. So with ADHD and autism, Spontaneous planning. So they just think, I have to go there, and he starts running. While autism need a planning. They can't plan properly. ADHD, they're always disorganized. They need change. They lack focus and they're forgetting information. While here autism, the need for planning is there. Routine order is not, they always require the routines. They require order. So if go into a room of a child with autism, very well ordered room. You go into a child with ADHD, lots of mess. So that's a typically we can find out. Children with ADHD, they cannot focus. But what you find, a child with autism, give them a car and he will play with the wheels of the cars for long hours. Hyper focusing. So that's the difference between the two. While sensory issues, teaming behaviors, emotional issues, executive function issues are common in both of them. Aggression and autism. Lots of people, parents with autism, they do quite well in the early stage and then they start coming to the developmental pediatrician with the complaint of aggression. So what goes wrong? Is a type of behavior intending to cause physical or mental harm, that is aggression. And in this case, children with autism show aggression out of frustration. They don't know how to interact with people. They want to communicate, but they cannot communicate, and that is why they usually do the. But only aggression, there is a particular thinking that I want to harm you. While autism, they actually don't, there's no intent of harm. They're doing it unknowingly. That's the important difference between. And then aggression comes with something called as oppositional defiant disorder. I don't want to accept what you are saying. That opposition of the system is the ODD, and that is important. It mimics again autism spectrum disorder, but it has got a purpose. In terms of autism, the purpose is lacking. Now, anxiety and autism, another dangerous combination. Most of the time, one of the theory of autism, that autism comes out of anxiety. Now, egg first or a hen first, we don't know, but anxiety is commonly associated with autism. In 42% of cases with autism, the anxiety is there. In typical cases, it's only 3%. Then children with autism have trouble assessing and expressing how they feel, which makes them anxious. Cognitive behavioral therapy and anxiolytics is an answer, but you have to be really, really careful in children with autism because these anxiolytics in autism may manifest. Problem behaviors may surface up, regressions may come with these anxiolytics, so we have to be careful. So in anxiety, we have got this typical child who gets into anxiety or a panic attack, goes into tachycardia, muscle tightness, stomach aches. While in children with autism, again need for planning, routines, order, hyperspectacing, need for information. So they are not going to show this tachycardia, all that. What commonly seen with a child who is anxious and autism, they have got this tachycardia, but will it be manifested in these kids? No. Who is having the tachycardia? The mother is having the tachycardia. It's not the child who is manifesting with that. Now this is a very important thing. Depression and autism. When I started first reading, the first point that came to me, the depression is in the mother and autism in the child. But over the years, especially there is a double A combination, adolescent and autism and depression. So that is the time we have to be very careful. Depression is related to the age and intellectual ability. Interestingly, it's more the intellectual ability, high chance is the depression because the child can think. So it's a very important part to remember. The signs are the loss of interest in what is happening around. Or in common with autism, noticeable worsening in hygiene. This child is not interested in cleanliness, the typical dressing pattern and all that. Chronic feeling of the sad. You find that the child is always sad, lonely, worthless and irritability. Especially it is very easily documented in adolescent verbal autism. That is where the depression can be really found out. And communication challenges can mask the depression. So we don't know. And that is why children with autism have depression. But luckily, they don't end up to the suicides commonly because that suicide requires a lot of cognitive thinking, which they may not be able to do. The treatment again is cognitive behavioral therapy and antidepressants in a very small doses, which is important. Obsessive compulsive disorders. Now here, unfortunately, even our pediatrician friends also mix these two words together. The obsessive compulsive disorders in one say, they say that this child with autism comes with OCD. No, OCDs are different from the repetitive restrictive behaviors in autism. There is something different between. What is different? OCD is more common among the teens and adults, while autism is earlier in the age. Autism typically, so you had some obsession, you'll end up into, I'm not able to do, so you'll end up in anxiety, then you go into those compulsive behaviors, and then you get a relief. But this takes a long time. This continues for a long hours. But when it to repetitive restrictive behaviors, they come and go, they come and go, they come and go. So there is a difference between these two things. So difficult to distinguish OCD from the repetitive behaviors which are hallmark of autism. But still it comes. But in autism, when you are saying, please avoid this OCD as a label, prefer to use the RRB as the part. So again, the OCDs and autism, a good quick comparison. OCD is a persistent, autism a repetitive part. So unwanted thoughts which lend into the to get the anxiety to be released, and because there is anxiety, there is a fear, and the child ends up into OCD. While in children, it is not tied to the fears. The fear is for the parents and not the child. So child is that most of the parents, what they say, he is fearless. He can jump from anywhere, he climb anywhere, he can do all these things. So that is a fearless part is with autism, while OCD is characterized by the fears which we have to remember. So now we have covered the first three parts, the genetic, cognitive and the behavioral part. Now let's discuss about the medical comorbidities. Now medical comorbidities, again a lot of things to discuss. Epilepsy and autism, you can have a textbook on that. So we'll be having so much literature is on that. So epilepsy and autism, there is a 30% correlation, while the typical it is 1 to 2%. Intellectual disability, epilepsy and autism come together. So always remember this, that is the child with autism and intellectual disability, think of epilepsy. Child of epilepsy and intellectual disability, think of autism. That triangle goes together. The risk of epilepsy in autistic children without intellectual disability is 8%, while that with the intellectual disability is 20%. It is 2 to 3 times. Syndromic autism with epilepsy, all these things which were discussed in the morning session, tuberous sclerosis, Angelman, Rett, and all these big difficult names which we can't remember, it is associated with epilepsy and autism together, and that is one of the reasons the geneticists say that autism is a genetic disease. So this is the one of the reasons we are thinking that genetic may be a big player. As children with autism reach the teenage age, surprisingly, epilepsy may not start in the early age. You have to remember this. I use this double A concept. Autism adolescent unfortunately comes with depression first, epilepsy second. We have to remember these two things. So again, just to comparison both of the things, epilepsy unexplained. Now how to differentiate? Epilepsy unexplained staring spells, while in children with autism, blank stares. They see through you, which is not seen with the children. They just blank about it. Involuntary movements are commonly seen in epilepsy, which are not typically there. The RRBs are there, repetitive behaviors, but they are not involuntary movements. Unexplained confusion. Children with autism, just after that epilepsy, they are confused. They are not aware of what is happening around. While in children with autism, again, hyperfixating. Children with epilepsy may be having severe headaches, which is not the common case. They may not be able to tell that headaches in that case, but blank stares, loss of focus, inattention, sensory issues and tics is something which is sometimes common in both of them. Lack of time, I'm going to move ahead, but sensory processing disorder and autism, at least 70. Now it's sensory processing disorder, DSM-5, part B of the DSM-5, fourth part is sensory processing. Now autism is sensory processing disorder is a part of autism, but still sensory processing disorder is a bigger circle. So in you and me also there are some sensory processing issues. In this August audience, there will be at least one me and second person they may be in this audience who will be saying that I don't like loud noise. Sensory processing issue. So this common in the but most children with SPD do not have ASD, but children with autism they do have sensory processing disorder. How to compare these two? In sensory processing disorder, there is difficulty in sensory processing issue, responding with and sometimes with the motor issues also. But in autism, it's added to that. Poor language, poor social, repetitive and sensory issues. Common with both, abnormal sensory responses, typical those seekers, avoiders, disregarders and meltdowns are common in both of them. So we have to remember this comparison. Something more to that is the movement disorders. So these movement disorders have been frequently identified with individuals with autism like ataxia, akinesia, dyskinesia, bradykinesia, tics and Tourette. So I am highlighting these tics as one of the part, and movement disorders along with ASD think of some syndromes like Angelman or Rett. So that is another genetic part of it. So in tics and autism, very common conditions. So we have to find us. I've seen at least one case every 6 months. I'm seeing either of this combination. So what is today? It's motor. So there is a motor tics as well as vocal. So all these tics come together and is associated with autism, ADHD as well as obsessive compulsive disorder. Motor tics can be simple and complex, while the vocal tics, throat clearing, grunting, and if you start looking at the people around, and you start finding tics in very common, and we start finding them. And the unfortunate part of it is there is no great treatment for that. So these tics come with a very it has actually no harm to the life, but the tics come with a long-term problem and it continue for a longer time. And these tics sometimes get confused again with the repetitive restrictive behaviors in children with autism. So just a comparison between two of them. Tics come later age, while autism presents less than 3 years. Tics, they build up, they start feeling that I'm going to get tics. Verbal child can tell about this, but this no feeling. We have to compare the tics in the steaming behaviors of the autism. These steaming behaviors, there is no such feeling. They get it and they start doing it. Well, it is not like that. Tics is more common with head and neck. While children with autism, hand flapping, finger fidgeting more on the periphery. Tics are never voluntary, but steaming can be involuntary as well as voluntary. And the tics, children, they don't calm on themselves. Well, autism, they usually calm on themselves. Whatever you do, the steaming continue ups and veins and waxes. So it continues like that. Now the next part is the sleep issues. Since autism has so many friends, I have to run through all these things. Every topic is a different part. Sleep is very common. Over 50% children with autism have chronic sleep problems, and over 100% of the parents with autism have sleep problems. So that is a common sleep issue with that autism, and sleep issues tend to worsen the behavioral challenges. It is commonly seen a child who has a problem with the sleep for say few days together, and the child goes into regression. So sleep issues, change of environment, that causes the issues. And now the medical comorbidities, so immunological comorbidities, I don't want to waste energy on that. So the brain cell mass activation is important, and all these immunological conditions together lead to autism. Now whether to call them separate or together is a science which will tell. Allergies and autism is another very common factor, and we need to, if you treat the allergies, it can improve the challenging behaviors on autism. So allergies, that hygiene hypothesis is one thing which is now coming up with these allergies, but lack of time I won't be discussing. Autoimmunity and autism is one of the research which is going on, and just to tell you, any inflammation, now this is very important for the pediatrician to take home. Infections worsen autism. So be very careful while managing the infections. So they'll end up into regression, and there is a autoimmunity part to it. And the last part to this part is the every it is discussed again and again, is the gastrointestinal disorders. So leaky gut, constipation, small intestinal bacterial, that is SIBO, inflammatory diets, chronic stress, everything makes the autism difficult. And if you manage that thing very easily, it can reduce those challenging behaviors definitely. And the last part to discuss is the premature mortality. We always discuss about morbidity, but autism comes with a premature mortality as well. So the mortality is 3 to 10 times higher for individuals with ASD. Reasons are multiple. They may be immunological, they may be sepsis, they may be seizure, they may be cancer. All things come together. So you have to remember this unfortunate friend of autism also. So treatment of comorbid medical condition, that is where the comorbidity is important, is result in a substantial improvement of quality of life in children with parents. So we can treat these comorbidities, and it is, who is the best person? The pediatrician is the best person. You don't require a developmental pediatrician to work on these comorbidities. So I'll just end with the concept. Autism has too many friends, but be aware of them. Thank you.
Thank you, sir. Thank you for your wonderful presentation. Sir's lecture will definitely help us to identify all the comorbidities associated with autism. Definitely addressing the comorbidities will help the child to outcome the disease. Thank you, sir.
Thank you, sir. I thank the chairperson and the speakers of this session.